planes here, right? You have two parasagittal planes, you have two transverse planes. Cutting the body, dividing it into 9 regions, right? Okay. So when you use these terms, you are helping people to identify where on the body, so pain could be a good one that you would be telling someone. And because of your knowledge of anatomy, you would know what organs are in that region. Okay. So we talked about the quadrants, we do the same thing. So we've got an umbilical region, on either side we have lumbar, it's right by the lumbar spine. So again, first you're assuming anatomic position, so right and left. So above the umbilical region is the epigastric. So what does that word mean?
On top of the stomach.
Above what?
The stomach.
Above. So we talked about this with like epithelium, gas. Here's your root word. And what's your ick refer to? Okay. See, it all starts to work. Sometimes. Okay, and then on either side, the epigastric region, you have right, hypochondriac, and left. So what does that word mean? When you think of a hypochondria, what do you think of? Yeah, something's wrong with, there's a complaint for everything. Okay, that's not what this word means. Did y'all talk about it? No. So let's break it down. Here's our prefix. Here's our root word. Here's our suffix. So what's the root word mean? Yes. Pardon?
Oh, the root word?
What's the rib? Ribs are made up of? So cartilage, bone. So this is referring to cartilage. Chondria. So what's the hypo telling you?
Under. Referring to.
It's another pertaining to. It's the way that it's, because it's like an adjective. Okay, so hypochondriac is telling you it's below the cartilage, so it's like below the ribs. Okay? Easier to remember when you think of it that way. Then you've got hypogastric, so that's telling you what?
Below the stomach.
Pertaining to below the stomach. And then on either side you've got right iliac and left iliac, so the bones, or inguinal. Sometimes they'll use that. So those are your 9 qualities. Okay, so which region is marked with that red dot? Right? Hypochondriac region. Okay. So I would give you a picture like this on the test and ask you to tell me. Okay, fill in the blanks. You have an example, so fill in the blanks with those 3. Okay, what's number 1?
Umbilical.
Say it again.
Umbilical.
Umbilical, okay. Right, number 2. 2. I can't hear your murmuring, so.
Left iliac.
No,
You said right.
right.
Oh,
Iliac.
Say it loud.
Left iliac region.
Left iliac, okay. And, okay, Paul, I'll give you the third one.
Hypogastric.
Hypogastric. Everybody got those?
Yeah.
Okay, next you've got the quadrants. You will probably use these terms more often, but not all the time. So here we've got mid-sagittal plane, we've got a transverse plane. We're dividing that abdomen pretty much and the pelvis into 4 somewhat equal quadrants. Again, when your preceptor is listening to you, the patients come in with right upper quadrant pain, they're starting to think, okay, what organs are in there? Because that is something you gotta think about. Is it the liver, is it the pancreas, is it the gallbladder, is it part of their intestines? Where is those symptoms coming from? That's why they're important. I am not gonna ask you, I'm not gonna give you an organ and say what quadrant it is. I mostly want you to be able to identify it on the body. Because often patients will point to those areas as well, or you may ask them to. So fill in those blanks. Jessica, I'm going to have you tell us the first one. Oakley, I'm going to have you tell you the second one. So I'm just giving you the one. Okay, Jessica, what's the first one?
Right upper quadrant.
Did you get it right?
Yeah.
Okay. Oakley,
Left lower quadrant.
did you get it right? Yes, good. All right. Okay, then we've got abbreviations. So you would use these in ordering. You would use these in documentation in your notes. You may see them referred to in diagnostic imaging interpretation as well. So these are abbreviations you should be able to identify. Okay. I want 2 volunteers. I want somebody who will stay in an anatomic position and someone who will point these out. Okay. Can you come up? Okay, Zach, you be the anatomic position. You're gonna point these out. She's got them right.
No, he's going to be the anatomy. Yeah, I was wondering.
Yeah.
Model here.
Okay, so have him face, here, come towards the middle of the class. There you go. Stand so they can see you. Okay, so y'all can help her. So a patient presents to a healthcare provider with pain in the right lumbar region. So,
Side of the belly button.
is that the right?
Yeah.
Okay. And right unilateral leg pain. Right leg, okay. Come over on this side so they can see you. I can see you. Okay. Okay, so the pain. Yes. Okay, the pain was felt in the posterior portion of the leg. Back of the leg. And it radiated to the distal lateral portion of the extremity. So distal lateral, okay? Can you see what she's doing?
Yes.
Okay.
Should I raise parts to see if this like see like
Say what?
Stand on the desk. Stand on the desk.
No.
No.
You fall There was some proximal muscle weakness reported in the affected leg. So higher. Higher, it's going to get higher. Lumbar spine radiograph was normal. Pain does not respond to anti-inflammatory. Then they'll be referred to an orthopedist. Okay, very good. Thank you. Thank you, Zach. Okay, so I want you to fill in the blanks with these. So let's read through it. So you've got a person to follow up for a degenerative joint disease of both knees. So probably osteoarthritis. Arrived at ambulatory, what's that mean? Walking. With the assistance of a cane, walking slowly with a fairly steady gait. On exam of the knees, there is marked crepitus that is palpable with pressure applied to the patella with the knees flexed and extended right greater than left. She has range of motion from 10 degrees to 110 degrees in the right knee. Pain is evident at the end of the extension of 10 degrees. The right knee is stable when stressed. Now, put in that blank a term that would mean pertaining to the front and the back. Just write it down, don't say it. You want to examine the right ankle. There's some mild tenderness on palpation above the right ankle. Right ankle moves from 0 degrees of dorsiflexion to 25 degrees of plantar flexion. From the blank pertaining to the side, joint line of the knee to the malleolus at the ankle, the right tib fib is 1.5 centimeters shorter than the left. There's a pigment change mainly on the blank pertaining to the back and blank pertaining to the middle aspect of the right lower leg, slight deformity over the blank pertaining to the front aspect of the mid-tib area. Okay, so fill those in and then we'll come back.
Is it common to abbreviate posterior to post? It's not on the list. I don't know if people just write it out because post isn't, like it's 3 more.
Probably, a lot of time they would abbreviate it.
Okay.
Don't have to. Yeah, I would say it'll probably depend on the practitioner, or if they're dictating it, or if they're typing it into
Yeah.
the inline. Everybody got it? Okay. Oops, let's look at it. I didn't put it. Okay, so the pain is evident at the end of extension of 10 degrees. The right knee is stable when stressed in a interior posterior. Valgus and varus manner. Examine the right angle. Okay, let's go down. The right angle moves from 0 degrees of dorsiflexion to 25 plantar flexion from the lateral joint line of the knee to the malleolus. The ankle, the right tib is shorter. Pigment changes mainly on the posterior and medial aspect of the right lower leg. There's a slight deformity over the anterior aspect. So you can see in ortho, or when you're dealing with pain or lesions, these are going to be common terms that you would use when writing to know. Questions about those?
What do you use ventral and dorsal?
No, they usually don't. In ortho, I haven't seen them do that. Seen them do it more with abdominal or surgical. Okay, let's.
What did you say dorsal kind of ends at your tail?
Yes.
And ventral maybe ends at the.
Yes, that would be very good guide. Okay, let's go back to these. We'll pick these up and then we'll finish for the day. This is yesterday's material. Okay, we're just going to look at interpretation. So look at the words in blue and write out the definition of them. So you got a post-op visit, got preoperative lab work, got a erythrocyte, a leukocyte count, hyperglycemia, hypokalemia, histology, lipoma, etiology of the lipoma, benign lesion, prognosis. So jot down your definitions of those. Everybody got it? Anybody want more time? We got plenty, so no hurry. Okay, I'm gonna call on you. Some is, I'm practicing, I'm not meant to embarrass at all. If you don't know the name, you can punt it to somebody else. How's that? Okay, let's see. Olivia, tell me the first word, the post-operative. Tells us what?
After surgery, the time after surgery.
Doesn't tell us how long, just tells us it's been after surgery. Okay. Shannon, tell us the preoperative.
Before surgery.
So before surgery. Okay. Let's see, Bethany, tell me the erythrocyte. So the red blood cell. And let's see, Fong, tell me the leukocyte.
White blood cell.
White blood cells. So they're talking about lab work, the red blood cell, white blood cell count. We have two labs that were abnormal. So Cassidy, tell me the first one. Hyperglycemia.
Increased or like above normal glucose in the blood.
Right, so high blood sugar. And then the hypokalemia, Kristen Nelson.
Low potassium.
Low potassium. Okay, very good. So histology, let's see, Sarah.
I put like tissue back, like study or tissue background.
Tissue.
Yeah.
Tissue study, that's fine. So we found out it was an encapsulated lipoma, so it's got a fibrous cap around it. So Sydney, what is the word? What's lipoma? Yeah, okay. So it's actually the OMA doesn't tell us it's malignant or cancerous. So it just tells us it's a mass. So it's a fat-like tumor or a fatty tumor. Any of those terms, if you use it, fatty growth.
Growth, okay.
Etiology, let's see. Pick names. T.
Unknown cause?
Say it again.
Unknown.
Not so much idiopathic. Etiology tells us what about something?
Origin.
Source, cause. You can kind of pick it up from context. So it says etiology unknown. The cause of it. Don't know where it came from or why it came up. Okay, but it's definitely. So I want to have somebody tell me with benign lesion, both of them. April. So tell me those two terms.
Benign is not malignant or favorable outcome, and lesion is the disease spot or affected area.
Okay, so it's a benign lesion, and so it's something we're not expecting. We took care of it, we took it out, favorable outcome, and not likely to progress. And prognosis, Olivia, I'll go back to you.
Okay. The disease outcome.
Okay, disease outcome is excellent. Okay, so see, you can interpret a report or a note that somebody has written. And I will post these today, so it gives you all of those answers there. So very good. Let's see, we got one more. So look over this one. Postoperative. I don't know if you've had the colitis or col, so that refers to colon. So this is colon. Colitis, colonoscopy, cytology, pathologist, dysplasia, inflammation, diagnosis, adenocarcinoma, colectomy, colostomy, malignant, oncologist, prognosis. Okay? So write those down. I'll go back up. I need more time. Okay, Hannah, let's start with you. Tell us the post-operative again. Okay, so this is the woman that's come back in after surgery, and she had a history of bloody diarrhea. She was diagnosed with ulcerative colitis, so Audrey, sorry. Audrey, the colitis.
Colitis, inflammation of the colon.
Information of the colon, okay. And let's see, Carly, she had a colonoscopy. What's that mean?
Examination of the colon?
Using a scope, okay, so they've examined the colon. And they found a lesion in the transverse colon cross. And so it was biopsy and sent for cytology. So Keely,
Some sort of injury or disease.
okay. Disease spot, okay. Let's see, so it was sent for, oh, sorry, did you do lesion?
Lesion.
Okay, so biopsy sent for cytology, so let's see, Casey.
The study of a cell, cytology.
A study of a cell, okay. The pathologist, let's see, Dim,
Person who studies disease.
okay. And it had advanced dysplasia, so Michelle,
An abnormal cell growth.
abnormal growth, right, dysplastic cell, doesn't grow, it's abnormally growing. And inflammation, so Kendall, swelling,
Heat, pain.
red, okay, angry. In the specimen, it confirmed a diagnosis, so let's see, Sarah, do I have two Sarahs? Sarah, that's Sarah. And you said, okay. So you all talked to Lindsay's the last year. We had two Lindsays in the class, they sat right together, right where you all are.
Is the process
Shh, listen.
the process of determining by examination?
Okay, so process of determining by examination. So Stacy, what's the adenocarcinoma?
Either a cancer or tumor of the glands.
Right, now carcinoma tells you it's a cancerous growth, malignant growth of a gland, so in the intestine, so a polyp of some kind. So the patient underwent surgery, she had a colectomy, so Taylor. Pardon?
Removal of the colon.
Right, and colostomy, Caitlin. You go by Caitlin? Yes. You have another name. Okay, Caitlin, so what's the colostomy?
So I have trouble with colectomy and colostomy because ostomy is an opening, so an
Right.
opening of the colon.
Right.
The colon was removed, so that's why I don't get it.
Well,
Not all of
but
it.
you have an end of it.
But
You
at
have
the
an
end
end.
you open. Like I know what a colostomy bag is, but just the actual terminology I get very confused on.
Okay, so
So
you
they
got
take it out and whatever's on the end, they just open it to the outside to the bag.
So they took out her entire colon, so I'm assuming they took off this, this, and this. But they left it, now it may be that it's the part of the small intestines, but they've taken that and then they have put an opening on the outside of her abdomen. That's the ostomy, is the opening. So ostomy, os is mouth, you can think of that, so it's a mouth to the outside. And ectomy is a removal, yes, Jim?
What does CARC in the adenocarcinoma mean? Does that mean like from the tissue?
CARC is cancer. Cancerous.
Cancerous tumor of the gut.
Yep. Okay. So a carcinoma always tells you malignancy. An oma just tells you it's a growth. Doesn't always tell you whether it's benign or cancerous. Servo.
So on the colostomy, I understand what it is, but so what would you want us to put as the definition if that were on our exam? Like how would you like us to verbalize that?
Opening of the colon.
Opening of the colon to the outside.
Would a decision be appropriate?
No,
Okay.
it's not an incision. It's an opening. So malignant, let's see, Kathleen.
Tending to become worse, progressively worse.
Progressively worse, okay. And then Kieran, oncologist.
Physician that specializes in cancer.
Cancer treatment, right. And so then prognosis, who did I not, Amanda? Disease outcome. Okay, good. All right, so you can interpret a note. That's a big thing. Okay, so some of you, big difference between now and Christmas, then Christmas and now. That's good. Okay. So let me tell you a couple of things. This is the last time I will teach midterm. From here, and this is the end of the material that will be on the midterm test, Ellen, what is it, February 8th? Okay. So I've given you all this is the format it's going to be, this is the material. You cannot talk and listen to me at the same time. So you've got the material, you know what the questions are going to look like. You can always email me, I'll be happy to address or come by and see me, so that you're prepared. We will not pick midterm back up again until the third module, which is HEAT, HENOT. We won't do this in nutrition, because there's not really a module set aside for it, okay? So questions about that? So it'll be self-learning at that point. Yes?
The PowerPoints will be
These I'll post everything I've done to this point, but I haven't given you yet. I will be out of town next week. I always check email, so you can always email me. I have 2 books left. If you want a book, you need to come see me by Friday. After that, I'll leave them with Amber if there aren't any. If there are more people than 2, do not panic. We'll order some off Amazon. I'm not going to hold that up for you. But at the end of this module, I will ask you, do you want one or not? After you've seen the test, and you've seen what we do. So what I will do from here on out is that I will post to D2L and say, here are the words, here are the definitions. I will cut and paste them out of the book. I'll put them in tables. Here they are. Study them. We'll do Quizlets, and you're on your own. A lot of it will be, you'll have those words given to you at the beginning. You will hear them throughout ClinMed, Farm, PAP. You'll hear all those words, so I would say, look at those words early in the module, because you will hear them over and over and over again, just like you've heard these through anatomy, and then we will do a test the same way every time. Questions about those? Okay, don't panic if it really is worrying you, always come see me. No problem. And then I don't see you for a couple of weeks now. The next time I see you, I think, is we start doing therapy, pharmacology type stuff. Yes.
What day will our test be? Is it the Monday after the session?
No, it'll always be before the end of the module.
Okay.
That I coordinate usually with the coordinator, or I'll talk to you all about it. So it's one that floats, but it's almost always the last 2 or 3 days, the Thursday or Friday of the module. It'll never be the same day as the test. It's too much. Other questions? You did really well today. The things I like that you did is you're in your seat, you're on time, you're engaged, you ask questions, and I can tell you're paying attention. Okay? And at break, you get yourself back in and you settle down and we go. That's good. I like that very much. Okay, all right. I'll see you in a couple of weeks.